Hi, this is Irma Jennings, health coach and osteoporosis patient navigator. Kindly do me a favor. Subscribe to my YouTube channel. This way, the information will get out and circulate to more people, and that's important. Like the this YouTube with a thumbs up and comment. All these things will help circulate this information so more and more people can hear it. Thank you so much for your efforts. Hello, everybody. This is Irma Jennings. And I'm thrilled to have one of my early teachers join us on our call today. This is Dr. Lani Simpson, Lani Simpson from California. I know Lani for a long time. A lot of you have read what I sent in the intro, but let me just go over it again. Lani Simpson is a chiropractor and well-known educator, clinician, speaker, specializing in osteoporosis and women's bone health. She's a doctor of chiropractic, as I said, with decades of clinical experience. One of the early voices advocating for a holistic root cause approach to bone health. And I want to get into that a little bit more than just reading this. Why don't I do that right now? One of the things that I found early on is that she has been looking at the root cause and go deep as far as the different kinds of blood work and different kind of the intake. Intake is very, very detailed when Dr. Lani does an intake with you. So she really goes deep. She's the creator of educational programs focused on empowering women to understand and improve their bone health. So she has tremendous expertise in the DEXA, knowing how to read the DEXA. She's a certified clinical densitometrist. There are not too many people around like that, which is a credential awarded by the International Society for Clinical Densitometry. This means that Dr. Lani is trained to interpret bone density scans, analyze bone-related lab work, understand osteoporosis treatments in depth. She did have a public appearance featured on PBS. It was a special called Stronger Bones, Longer Life. It was absolutely brilliant. I was in the audience. This was in February. We think it was in 2019, not sure of the date, but it was in Minnesota. It was freaking cold. It was cold everywhere. But she was there giving this wonderful presentation that took so much prep, and it was very professionally done. She's the author of books and programs focused on bone health and education, and a speaker who has taught thousands of women and healthcare professionals. So that's what I want to say about our guest tonight. These are her books: The Bone Health Guide. Everything is no nonsense, right? Because it's like let's get down to it. Let's get to the bottom of it, and let's get through some of the hype that's out there that's very, very confusing. So, is there anything that you want to say about yourself, Dr. Lani?
No, that's good. I'm raising monarch butterflies from my garden. I mean, that's a good thing.
That's a good
So
thing. That's a good thing.
add that. I love my monarch butterflies.
You're making a contribution to nature.
Yeah, I have about 60 out there right now.
So, standing room only. I would like to get right into what we want to talk about, which is the whole thing about teeth. Osteoporosis and teeth, what's come up within my community. Well, let me go back to something. Some of you may not know me. I am an osteoporosis patient navigator, which means that I find people like Dr. Lani and various other doctors who deal with osteoporosis and who deal with gut health and who deal with various other aspects, exercise, all things that are bone related, and I refer my clients out to them. So that's me. I've been in this field. I've been a health coach since 2003, but more importantly, focused on osteoporosis for the last, I want to say, 9 years. I met Dr. Lani because I thought that I reversed my osteoporosis, and she gave me the, no, you didn't. Let's take a look. And we went deeper into looking at my DEXA, and DEXA is very detailed. It has a tremendous amount of information, and it's very confusing. And people can think at a glance, I'll just look at the radiology report and know what's going on. But that's not true. It goes much deeper than that. So that's how I first met Dr. Lani. And now we're going to talk about the whole idea about the bisphosphonates and they can't hear me? Okay. Bisphosphonates and dental treatment. So do you want to jump right in with this, Dr. Lani?
I can hear you fine.
Okay.
So, just so you know. Um, well, first of all, I think I want to dovetail into what you were just saying in terms of bone density a little bit and then jump over there, which is that um, the fact is, in general, there's no osteoporosis specialty, period. And doctors are not required to be trained densitometrists to put their name on a report. This is why the machine itself, because we hear about bone densities being incorrect, is not the machine, it's the operator.
Mhm.
And the doctor that's willing to put their name on the report without looking at the images. So I just want to say this piece. When you get a bone density report or when you go in to get a bone density exam, ask for the CD or the images. The report means nothing to me because I often find mistakes. So you want to make sure you get the images, and the images should look like little x-rays. If you have my book, look at the back of the book, shows you exactly what those should look like. So I'm all about diagnosis, and I want to also say no doctor should be treating a bone density test, period. They should be treating the person. That's not what's happening. Now I'll go to what now I'll go
No,
to
but
what
let's say that again. Let us say that again. No doctor should be treating a bone density.
of any persuasion. Yeah. So that means an alternative doctor giving you supplements. No. It requires understanding bone density. It requires lab work that needs to be done individually. I work with a case today, and the woman has a kidney problem. She's got a few other problems that have not actually been delved into, which drives me a little bit crazy. So lab work is very important. History is important. And it turned out, Irma, that she had primary hyperparathyroidism. And she had it removed, had the little tumor removed, which are typically benign, but no one bothered to tell her, oh, by the way, that could cause bone loss. So, I run into this stuff all the time that people are not trained and they're treating simply the bone density test. So it's important that's why I wrote the book, to understand what you may be needing. Because you know what? If you've been diagnosed with osteoporosis or even osteopenia, this is going to be a discussion you're going to be having with every professional that you have for the rest of your life. So you want to be able to be in the room with that doctor, which is why Irma does what she does because she's a patient advocate. So, but you want to learn it too. I mean, unfortunately, that's the way it is. We can't just trust people to give us the right information because they're not trained, most of them.
But I want to say something. We're going to be doing a lot of this. When you get a diagnosis, you haven't failed, right? That's a very important piece. You haven't failed. It's a piece of data that you then have to tend to, or it's a diagnosis that you have to tend to. And many of us feel like, oh my God, I did everything. I did everything. I eat right. I exercise. I love my partner, and here it is. And it does happen. Sometimes it's idiopathic. Sometimes we could find a root cause, but it's not that you failed. Okay. What would you like to talk about?
And then I'm going to add to that a lot of times it's because of what we did or didn't do in our formative years. So we're building our peak bone mass heavily during our teenage years. Watch the kids, just sprout up in puberty. They're building bone. I have osteoporosis, and yes, I do have osteoporosis because of what I did and didn't do in my teens. So it's not so easy to just reverse this, by the way. And I didn't eat well. I smoked cigarettes. I did a lot of things. I mean, I'm lucky I've never had a fracture, even though I have osteoporosis, because my bone quality is still good. And that means the bone density, that we can learn more about our bone health through understanding the bone quality beyond density, which means your bone's ability to resist impact. So some of us may have that genetically. I think I lucked out genetically because I did so many things in Irma that that weren't good for my bones. But at this point, and I'm going to be 77 this month, I'm going to be starting on an anabolic medication, which I'm thrilled about because the anabolic medications build bone. They're amazing. So that's what I'm going to do. I've been on hormones, low dose hormones, to maintain things, and I'm still going to continue with that, by the way. That's a whole discussion in and of itself.
Okay, two things. Wait.
Okay.
Because,
Okay.
because the TBS, when is it Hans Ditter?
Trabecular bone score. That's the
Right, but is it Hans or is it Ditterman? What's his first name?
Didier Hans is the one
Didier
that developed that.
who
Yeah.
developed the software because Dr. Lani had been talking about this for as long as I've known her. It's not just density, it's quality, quality, quality. This machine comes out, this test comes out. It's not readily available, but they are around the US that you can get the trabecular bone score,
But
which
you have to ask for it.
you have to ask for it, and sometimes you have to pay for it, but it's really worth it because it's part of the whole picture. So the bone density, the DEXA is the outer part, the TBS is the inner part, and we need to know
Well,
what.
let me just add to that a little bit. So the TBS is the structure, the bone structure. The density is simply density. So if you look at like say you have a piece of chinaware and it's dense, but you can drop it and it'll shatter. So that's the structure. So I just wanted to add that because I think that helps people see that.
Understand, right? Okay, and then the low dose hormones you've been also talking about. Let me go back to the TBS. I just can't say this enough because you've been making a lot of noise for a long time in a positive way, why this is so important. And people, it's glacial as far as the movement of this understanding and the opening up of this understanding why this piece of the test is so important. The low dose hormones you've been talking about from the beginning,
Yeah,
right?
it's in my book. My book was 2000, came out in 2014, and you might think that that's old, but the information's still pretty darn good. And I was saying the same thing back then about hormones, and understanding bone structure, all that, bone density, that's all in the book. So,
So, there's some of us on the call that cannot take hormones. That's a whole nother thing.
yeah, it's not for everyone.
And when you're looking at, let me just put this in the estradiol number. What is the number that you're looking at as far as the blood work?
So, yeah, a lot of times, it's not how much, like, I'll even throw vitamin D in here because it irritates me too. And doctors are just, oh, take 5,000, take 10,000. It's a hormone. So, what matters is your blood level. So whether it's estrogen or say vitamin D, it's not how much I'm taking, it's what my blood level is. So with estradiol, which is what we stop making estradiol after menopause, I like to see it around 50. That's enough to uh, slow down the osteoclasts, those bone cells that chew up bone, because they go crazy at menopause. Some women can lose 15%. That's why at age 60, I'm dealing full bone osteoporosis with people because the doctors didn't tell you. Oh, by the way, we should have a conversation. You're heading into menopause. Did you know you could lose like 10 or 15% if you don't do hormones? Maybe you can't do hormones, but now maybe we need to really look at your nutrition, digestive health, get you exercising. You get my point.
I
And
do.
vitamin D, my sweet spot is 45 nanograms ng/ml per milliliter.
Mhm.
Higher than that, and I had a case today where the woman, her serum calcium was 9.9. She previously had primary hyperparathyroidism, which is diagnosed by a high calcium. Well, guess what? Vitamin D can do that too. Her vitamin D was 61. I don't think she's having a recurrence. I think she's having too much calcium in the blood because of vitamin D, because too much vitamin D can also, by the way, impact your bones negatively.
Okay, so that was a quick little sidebar thing. So let's get into the mouth.
Okay. All right. So in terms of osteoporosis and teeth, this could be a whole thing here, a whole hour, but I'll shorten that up, Irma. So oral health is important, obviously, and a lot of times people will say, "Oh, I have bone loss in my mouth," and they already have osteoporosis. It doesn't mean that the osteoporosis is causing that. More often than not, if your dentist has told you that, it's a local infection, and it's important to understand that. Now, some of us do have a lot of loss in the bones. I myself do. I have a mandible that is very, very thin due to poor dentistry and extractions. But when I had a tooth pulled, that doctor was, I mean, Irma, he had his foot on the thing trying to pull that thing out. If I had weakening, it would have come out easily, and infections and things like that will cause that. So I just want you to understand people with sort of borderline osteoporosis, unless you have periodontal disease and things like that, probably not going to lose your teeth. now. I mean, if you don't do something about your osteoporosis and you're -4, yeah, that might start happening. So there's a lot to know about dental health, but the thing is that you do your best, obviously, to control periodontal disease because that's the key. And one of the things, if I had periodontal disease, that I would be doing is swishing around baking soda in the mouth a few times a day. So I put it like I tell people, put it in a little container and just swish it around the mouth. Why? Because periodontal disease creates an acidic environment in the mouth.
Mhm.
So that can be helpful for periodontal disease, among other things, obviously, people do.
What's come up in my community is that people are on anabolics and they're having teeth issues.
You mean bisphosphonates?
No, no, anabolics.
Anabolics are used to treat problems with the teeth. So if they're saying that, then the only one that might do that is
Yeah.
Evenity. But I don't,
Yeah.
I would have to see I don't know.
Well, I'm just telling you,
Okay, go ahead.
that's coming up in my group on Avidity with teeth issues. We're talking
Okay,
about,
tell me what the teeth issues are telling you about.
so deep scaling, the pockets are getting deeper, the teeth are loose, that kind of thing.
Here's the thing. That's not all going to be because of Evenity. That had to be a problem before that. That's just not going to happen. So we have to be careful about when people are telling these big stories. Maybe it could happen. I've never seen it. And sometimes people will say, "Oh, I've been taking Avinity or I've been taking some medication, and 4 months later I got a fracture." Well, that was there anyway. Do you see what I'm saying? But what you're describing, such an extreme case, I can't believe that their teeth were perfect before they took Avinity, is what I'm trying to say. So I'm just very cautious about that kind of uh, yeah, it could, potentially could cause there are, very, very, I mean, it's such a tiny, tiny percentage, and they're somehow finding you where it could cause osteonecrosis of the jaw. Osteonecrosis is areas of dead bone. That can happen anyway. But the reason Avinity might do that is because it does increase, it has the osteoclastic component too. So it works both ways, osteoclast and osteoblast.
So what Dr. Lani is talking about is the Avidity starts out in one capacity as an anabolic drug to build,
Building,
and then
yeah,
it flips over and it breaks down. Is that a
yeah,
fair?
yeah.
I mean, just in simple terms.
Well,
Okay.
toward the end, it
At
actually
the end.
actually act as an anti-resorptive,
Right, right.
and because of the suppression, is why people can end up with osteonecrosis. It's extremely rare. That's why I want to get across here. So if a bunch of people somehow are saying this, I question it.
Well, I'm
That's,
telling you, out of my group, there are three. So it's just, so we'll talk
they all may have found you. It could be just a quirky thing, but again, I'd be asking, well, what were you never had tooth problems because scaling and having to have teeth pulled?
Mhm, mhm.
That's infection. That's not just loosening.
Okay, so let's get back to bisphosphonates and what is there, from your experience and listening to that gentleman, that dentist speak, what was your takeaway from that as far as, does everybody know what a bisphosphonate is? So I just want to make sure that we're speaking to everyone. Bisphosphonates, there are 4 or 5 of them. There's Fosamax, which is alendronate. There's Actonel, which is resendronate. Boniva, which is not used so much anymore, but it's
Not terrible drug.
a terrible drug. All right, we're not even going to list that one. Reclast, which is zoledronic acid. Prolia, which is a whole nother conversation. Then that's boy. So those are the primary
No,
bisphosphonates.
no, no. Denosumab is Prolia. That's not a bisphosphonate. It's in
No,
the
that's a
category.
correction. Right. So that doesn't fall into that category. It's on its own. So basically there are 4 of them, counting Boniva, there are only 3.
There's a ton of them actually, and there's more coming out, that are what do you call it?
Yeah, they're off label or something. They're right
Yeah,
there.
yeah.
Right. Mhm.
But okay, so basically bisphosphonates are medications that work on osteoclasts. Those are the bone cells that can kind of go crazy and they chew up bone. Think of it like that. So what the bisphosphonates do is they slow that process down, but they don't also increase bone density. That said, they do reduce fracture risk. So there is a place for them, but not for long term. It's like a 2 or 3 year kind of thing, in my opinion. And not just my opinion, but a lot of doctors. Because if you only suppress osteoclasts, then you can potentially end up with bone that is more brittle. Why? Because the bones were supposed to turn over bone, meaning osteoclasts get rid of old bone and the osteoblasts build up new bone. So if you upset that too much, then you can end up with what people say a bunch of old bone. That would take a long time to have that situation. But then nevertheless, 2 to 3 years, I'm okay with in that category of medications. But the way we're learning now, that's probably the best way, and it's not going to catch up for a while, is to do a bone builder first. It stimulates your body to build your own bone. I was talking to Kelly Crone today, who is like the godfather, if you will, of Forteo, and it's a bone builder. It's not enough to just say something is going to build bone. What's the fracture reduction?
Mhm.
Fracture reduction with Forteo is something like 80%. It's incredible. So if you gain 10%, the fracture reduction is 8 times what you would expect with that. That's huge. Absolutely stunningly huge. So we should be doing those first for most people and following with the bisphosphonate to hold gains.
So let's pause for a second with that. And we know what the problem is. You and I know what the problem is, that the insurance company's like, no, 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 we want you to fail on the bisphosphonate first.
That's right.
That's typically the protocol, and that blunts some of the anabolic as far as the impact. So we have, when we're in the space where it's time to get medication, when we need to know whether or not our doctor can actually fill a script, deal with the insurance company. It becomes, not only does the patient have to be convinced that it's time, but then the patient has to ask the doctor, how are you dealing? What is your billing company? Can you get this through the insurance?
Okay, so here's sometimes, and we were talking about this in my doctor's group today, that Mike Lewicki was saying that sometimes he, doesn't give a woman an anabolic until they're 65 and have Medicare, because Medicare actually will pay for Avinity. Now, not Medicare Advantage.
Right.
We refer to that as Medicare Disadvantage in my doctor's group,
Mhm.
but it has to be the other Medicare, not Medicare Advantage. That will not cover you. So, um,
But let me,
and I just, what's
okay,
that?
go ahead.
Oh,
I'm
I
sorry.
just want to add that Cheryl over in the chat was just asking, is there a fracture reduction on a bisphosphonate? Yes. So there's times in which I'll do it, but you have to understand I'm going to be looking at bone turnover markers, which tell me how is somebody actively losing. If you have one bone density, you don't know if you're actively losing. Maybe it happened when you were a teenager, right? Are you actively losing? That's very important to understand. The bone turnover markers tell us that.
So what Dr. Lani is saying is that we don't go from DEXA to DEXA. We look in between the bread, right? And say, okay, wait a minute, let's see what's happening right now with the bones. And that's what Dr. Lani is referring to when she talks about the bone markers. So
Bone turnover, yeah.
bone turnover markers. So there's the C-telepeptide, which shows whether or not you're actually losing bone. And so a couple of things. What is your number that says, okay, you're losing?
Okay. First of all, everyone on this call, if your doctors have not ordered it, and I always say to people, know why you're in the doctor's office. If you're in there to get lab tests, don't ask about calcium. Just don't do it. Get the lab test. So CTX, short for C-telopeptide. Telo, Telopeptide. Pro-collagen, the P1NP, pro-collagen type 1. Those two I order on every case because I want to understand their bone turnover. So the bone turnover, I would like to see the CTX around 275 or lower. And the P1NP, if somebody is not on an anabolic medication, should be around 30. Now, the P1NP indicates osteoblastic bone building activity. So does the P1NP then being high, is that a good thing?
Yeah.
No.
No.
Some doctors, Lewecki, a lot of times doesn't even bother with the CTX. He just looks at the P1NP because if it's high, Irma, so this is a tough one to get. It was tough for me to get initially. If the P1NP is high, it's indicating bone turnover because they couple with each other. But the CTX is always going to go faster. It's
Right.
not making it up. You're going to be losing. So the P1NP, if it's higher than 30, they're not on an anabolic, is indicating bone turnover, meaning bone loss.
Okay, we need to pause for a second because I
Yeah,
have.
I know, I know.
All right. So this is one of my long-term clients. After being on Fosamax for 5 years, with my bone density bringing me back to osteopenia. Now, so that's longer than the 2 to 3 years that you were originally talking about with Fosamax. What does that client do now? Now, of course, you can't diagnose her, but what is the next move after long-term Fosamax?
Okay, so first of all, bisphosphonates, Fosamax, Reclast, those drugs, not denosumab, which is Prolia, but the bisphosphonates, they are taken up in the bone, metabolized into the bone. They have a long half-life of 10 to 12 years. It's in your bone. It can then have a blunting effect on an anabolic if you want to take it. That said, you'll still gain on an anabolic. Sometimes we are unable, for whatever reason, to get an anabolic. It doesn't mean that the other medications are not helpful. And it's just how to use them judiciously, how to follow them, and why I want you to get bone turnover markers before you start a medication, if possible. Some of you have been on them perhaps already, is so I understand what your bone turnover was before you started a medication. So let's say you had high bone turnover and you take a medication. I would expect you, unless that something was fixed, like poor nutrition or digestive problem or kidney problem, whatever it was, I would expect you to probably go back to that. So I'm going to be very cautious and watch you very carefully in terms of whether or not the medication is actually slowing down that bone turnover. If you were fairly stable, meaning the CTX was around 275, P1NP's 30, that's stable. And you have a -4. Well, that still needs to, in my view, be treated, especially as that's again, it's going to be a higher risk factor.
But for the person who's been on Fosamax for 5 years and now she's getting off of Fosamax, is it just watching her CTX?
What, has she had any fractures?
Well, she fell and she broke,
Ever.
but ribs don't count, right?
Ribs do count. But if she fell and broke a rib, yeah, I would not necessarily count that because, I'd have to look at the rib and blah, blah, blah.
Right.
But ribs, we now know, like say if you're coughing, and break a rib, that counts. Okay, so she fell, broke a rib,
Mhm.
never broke other bones. Let's just make it real simple. No fractures at all. Okay.
Yeah.
She's been on Fosamax for 5 years. Boo on the doctor who did that, unless they were, unless her CTX was really high. But the point is, she's got it in her bone. Follow the CTX. If it goes high, if it gets up to like 325, then maybe something needs to be done again, but she might be fine. Guess what? We now know that Reclast and some of these bisphosphonates work for up to 6 to 8 years if people follow the bone turnover markers and to make decisions based on that, not on bone density.
Which is an excellent point. Excellent point because that question came up as far as the reclass and how often to do that. But we're getting way off of the dental thing. So as far as the biz,
I, I can't help it because there's base information here. Yeah,
I
go
know.
ahead.
But as far as the bisphosphonates and dental care, what was your takeaway from that gentleman's presentation from the bone group, that doctor's group?
Well, you're at increased risk if you're on bisphosphonates to some degree. But it depends on how serious your case is.
Mhm.
And we always have to make decisions. There's going to be doing nothing, as you know, whether it's a medication, can cause fractures. Doing something is going to bring up some other things. So I would have to look at the case individually. So in this case, it's 5 years.
Mhm.
You're looking at dental health. I would want to know what the dentist says. I would want to know, what the state of her, gums are, things like that. And people who have osteonecrosis are treated with Forteo or Tymlos.
Seriously.
Seriously.
Oh,
And
didn't.
Paul Miller talks about that quite a bit. He's done that with a number of his patients. So again, that can happen with anybody, even without the medications, but the longer we're on them, obviously the increased risk. Now, if somebody is taking Prolia, which I'm not a fan of, there are certain cases I would say yes. The injections are every 6 months, so try to avoid any kind of dental care until, wait until before you're going to do the next injection. Um, and that would be beneficial. But again, if you're in a pickle, I'd say go for getting the dental work done. That's what I would say.
So there is.
And let me be clear about this. Um, the dental work it has to involve bone. You can get cavities filled. You can get all kinds of work done in your mouth. You can get what do you call it when they do the nerve thing? Um, when they remove the nerve in the tooth?
A root canal.
Root canal. I can't remember everything. Root canal. That's no problem. It's only when they're doing some kind of thing that is really significantly involving the bone, like pulling a tooth.
All right. Um, and I want to talk about my case for a second, but it says that Cheryl, her Medicare Advantage just paid for 2 years of Forteo. Forteo, and now she's on Fosamax. You see that?
Good.
So that's good. But in general, you have found that Advantage plan does not. I think it's
Well,
state.
no, I said, no, yeah, it's usually pretty tough. So, it all depends on the area you live. There's so
Yeah, yeah,
many
yeah.
things, but just you have to check. Yeah.
You have to
Good.
check.
That's great.
That's good. That's good to hear. Is there all right. I want to just say one thing because I have been diagnosed with PMR, which is polymyalgia rheumatica. It took me about 2 months to be able to pronounce that. And it happened started with the neck, pain in the neck, the middle of the night, in the shoulders, down the arms, some of the legs, in the hips. I thought I was crippled. I don't know what happened. It came on just like that. I went to the rheumatologist. She said, you have PMR, and she put me on prednisone. Now, I was just at my endocrinologist today, and she's like buckets of tears. How long have you been on it? How many? You're 15 milligram for how long? And she was going on, and she's like, oh my God, like, well, we got to do
Not
something.
helpful.
Pardon me?
But it is true. Now, there's no question that the biggest bone kicker are steroids, period.
Yeah.
You have to take it. I know your case. You have to do it. So would I be considering an anabolic right now? Yeah.
She wanted me to go on Fosamax. So, I mean, the point is not to discuss this, but it's very interesting because what had happened, another member of my community said, check your teeth, check your root canal, see if there's any bacteria there, which I did do. I did one of those 350 things. And it is. There's bacteria there. The tooth, my dentist's opinion, has to be removed. So I'm thinking to myself, there might have been a low level of inflammation happening in my mouth. My root canals are very old.
Okay.
Let's get this checked out. I don't know that this is the root cause, but I'm just trying to clear up.
Well, to determine if there's an infection by a radiology exam, you'd have to actually see bone loss around that tooth. There's no way to see bacteria. So I'm just saying, I don't
Right.
know.
So then she was
Yeah.
saying,
Yeah.
bone loss.
There's a bunch of questions coming in over here. I don't know if you want to go to that, but go ahead. Let's move along and then we can do some questions.
Okay. So what is ideal PA1NP if on an anabolic such as Tymlos after 1 year? Can it get too high? Well, we've seen those very big numbers, right? That are absolutely saying that it's working very well. Have you had that experience?
No, the P1NP can't be too high.
Can't.
Okay, so if you're on an anabolic, remember the 10-point rule. If it's 10 points above where you started, it's working. The higher it goes, that's just fine. It's not going to, sometimes they'll get in the 200s, 300s, fabulous. So, and the CTX also on Forteo, see, it starts getting complicated, but on Forteo and Tymlos, it's going to be high. You would think that would be bad, but in the case of these two medications, no. It removes old bone, lays down new bone at the same time. And in the end, the P1NP or the bone osteoblasts win out. That's the difference. So you get spanking new bone. I mean, again, the antibiotic, I'm a huge fan. I mean, I see what it does. It saves people's lives and their future independence. So I'm a pretty big fan.
So I've read about high P1NP and CTX, but can't find a whole lot of information on low P1NP. Perhaps Dr. Lani can address the low values.
So the low values, some people, when we look at things, and Kelly Cronin, I was talking with him today, it's on a bell curve. So when you look at things and they say, well, this is what the norm is, right? Well, maybe you're on the lower end of that in terms of your norm. Some people could be maybe 20 P1NP or the CTX being 100. Well, is that a problem? Is it a problem? Is your bone not working right? We don't exactly know, but we do know that there is a fundamental understanding that there's sort of this average that we look at. But this then requires a doctor to actually think and have enough understanding about bone biology and physiology to be able to think through things on your behalf. But I wouldn't necessarily say if your P1NP was 20 that it's a problem. And by the way, never trust one set of a lab. Never. And especially bone turnover marks. I like to see a trend. If you see something that's off in your blood work, think about dehydration because it affects so many tests, thyroid tests, all kinds of tests. Drink water before you go in. Fasting doesn't mean don't drink water. But the thing is, retest. Just redo it again, especially if doctors say, oh, we got to start, they do a 24-hour urine and your calcium's high. Oh, we got to start you on a medication. Heck no. Let's redo that. And, I mean, yeah,
So we
I'm a
have
little passionate about this, you guys. So,
Andrea is asking, she's confused. She thought that you had said that very high P1NP.
yes, I'm glad you said that so I can reiterate.
Okay, thank you.
So, if the P1NP is high and you're not on an anabolic, in other words, people, if you're not on an anabolic, the P1NP should be around 30. A good uh, indication that your bone is stable is the P1NP would be 30 and the CTX would be around 275 or lower. I mean, if it's 325, then you kind of, retest and just see what you get.
Mhm.
But, that's where we start getting on the slippery slope. If your CTX is 600, there's no doubt you're losing. And then the P1NP in that case would probably be around 70 or so. That's blown turnover that is losing.
So one question that came in, osteoporosis seemed to be correlated with receding gums in the mouth. I think I remember you saying that a long time ago. Is that true?
Well, receding gums can be brushing your teeth too hard.
Hmm.
I mean, I had that. I actually had that. And this was years ago. And so I'm thinking, oh my God, this osteoporosis, my teeth are going to fall out. No, I was like,
Right.
doing that to my
This way,
teeth.
back and forth, back and forth. That's why we.
Yeah. So, again, it can be something very simple.
Mhm.
Um, and, so I don't know. I mean, it can be simple or it can be something more aggressive, of course.
She's asking about,
But receding gums is usually going to be a periodontal issue.
yeah, I have
The
that.
pocket's getting loose and teeth kind of moving back and forth. But you're looking at somebody who's probably 90 years old
No,
and you're going like that.
no, 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 not 90.
For the most part, Irma, for the
Okay.
most part,
I'm just
I
saying.
just think generally that is the case.
Okay, okay. Um, I know you're not going to answer this question. What about brushing the gum line twice daily with hydrolyzed, I hope I said that, type 1 collagen peptides? You don't, first of all, you don't, I don't think you're a fan of collagen. Is that true?
Taking collagen, I do pre-collagen. I give my body what it needs to make collagen, but no, I don't take collagen supplement.
You take pre-collagen in the form of what?
Well, vitamin C
Vitamin C, right?
and horsetail, of course, that gives you your silicon.
S-
And those are the building blocks for collagen, as well as protein. I mean, you need to have those things.
You need the protein. How much C do you take?
How much who?
C, vitamin
Oh,
C.
vitamin C. Um, I try to get small amounts during the day because I get affected by that and digestive, and I stay away from the uh, citrate form, actually, even though citrate is so good for the kidneys.
Mhm.
Um, and which is why I recommend, as far as a supplement of calcium goes when needed, uh, calcium citrate. It's
Mhm.
good for the kidneys. But anyway, I take small amounts throughout the day. I take less than 500 a day as a supplement. Because interestingly enough, vitamin C can also turn into oxalates. So you have to be, I'm not a big fan of doing high doses of it, but that's plenty. And getting foods with vitamin C is important, obviously. And then I take BioSil. So BioSil is the
You've been
supplement that I
Biosil
use
for a
for
long
the
time, right?
horsetail. Yeah.
You've been doing that for a long time. Biosil, you buy it at a health food
Yep.
store.
Yep.
And what is it?
It's horsetail.
Oh,
And that is silicon. And then we know that those two things help support our collagen production.
you could buy horsetail in an herb.
I would
And
this particular supplement actually has some science behind it. And in terms of because they say skin, hair, and nails. Well, something impacts the skin, hair, and nails is going to impact your bone part likely too.
what are you going to drop a name as far as the product that you use?
Biosil,
Ah,
Biosil,
okay.
Biosil.
Okay. So Andrea's CTX was 709 and her P1NP was 112.
A good example. Now, and that's a very good example that you have very high bone turnover, and you're losing. There is not this whole thing about, oh, if your CTX is high and your P1NP is high, you're fine. No. So I don't know. Do you know why you're losing? Do you have a sense? Is there a digestive issue? Those are all questions that you should be asking yourself. Along with your doctor should be very interested to look at your blood work, to order the right blood work, to actually rule out secondary causes if they can. And as you pointed out earlier, Irma, it could be idiopathic. It's hard to know.
Her CTX went down. She went on hormones. Her CTX went down to 259 and her P1NP is 96.8.
That P1NP is still too high, but I would retest it again. Is that one accurate? You can have like 10 in a row, but again, who knows?
Right.
Maybe it'll come down. If the CTX went down, maybe that P1NP in your case is going to take a little while to come down in the same way. But yes, typically they're going to couple together.
Coupled together.
So they're going to act together. And that P1NP should come down as well.
So Bondia. That's one of the reasons why we're on this call. And thank you, Kathy, for reminding me of that. What do you think of it? What's your opinion on that?
Yes.
Yeah. So, anything else
They
besides that?
make these claims, and I know you had Osteo Boost on the thing to talk about too. They even have studies behind it, but how strong are the studies? You look at the studies, there's no supplement. I've been at this for 30 freaking years, and I have been hoping to find a magic bullet. But what I have found is that we need a bunch of things. We need the vitamin D. If there's anything that's been magic for me, it's been vitamin D, correcting that, and that hasn't been good. But you know as well as I do, Irma, that the diet.
So the Bondia
So
is, but Bondia, but I don't even know how to pronounce it, but it's gotten so much
Bon dia. I
Bondia.
know. Well, they've got great advertising.
That's
Look
great.
at look at what happened with the osteo. And I spend my time, a lot of it, blowing up this kind of stuff. Some of you might have heard of OsteoStrong. Go look at my video. It's free over on YouTube. I have 80,000 views. I've saved a lot of people from that horrible company that lies to people. I can't stand it. Excuse me, I'm getting riled up.
You get all worked up and there goes the blood pressure. All right. So would high intensity exercise like Onero increase bone turnover?
Yes, for short term, it does. And it'll show a little P. It's not long lasting, but yes, it does. But over time, a program like that, where you're really stressing the bones, it works.
It
And
works.
not everybody can do that level of exercise. I get it. I'm just telling you what we know that works in terms of exercise. But is it going to bring down somebody who has a 700 CTX and a P1NP that's that high? No. There's something off there. If those, and why I like to order those two together is that P1NP is mirroring the CTX. There's loss.
Mhm.
What would I guesstimate that based on my personal clinical experience? 1 to 3% a year. But you don't want to keep doing that. It's not like you're dumping out 3% a day, but over time, that level is not good, obviously. There's
So,
something going on.
so you said something very quickly. 1 to 3% a year is what is what people typically will lose as
I'm guesstimating from my clinical experience. But I wanted to finish with just for a second because you had the Osteo Boost on your list.
Yes, I did.
That study was 100 people, 100 women. 50 used the Osteo Boost, 50 did not. What could go wrong? And then they came out, it's a terrible study. Then they came out with massive, absolutely massive marketing. That's what they do. That's what the pharmaceutical companies do. They all do it. That's why we have to be on guard and be skeptical, open, but skeptical. I'm still looking for the perfect thing. I don't think it works at all. It doesn't make sense to me.
So Osteo Boost is a belt that sits on the hip, right? And it's for
Yeah,
people that have supposedly osteopenia. How does it work?
it provides a bit of vibration on the sacrum. I'm sorry. I'm saying don't waste your money. That's what I'm saying.
But
On your time.
but now Medicare is covering it, right?
I don't care. Well, they'll do that. So people have these studies. It gets over on PubMed. Does that mean it's actually good? It was a double-blind study. 100 people. Is that proof? We saw what went on with Fosamax. Let me just give you that bit. It all looked good. But then when people were on Fosamax, for 10, 15 years, we started saying, oops, they're starting to get fractures because they're doing it too long. Studies and double-blind studies are maybe, if you're lucky, 1 year, 2 years. That's it. And a tiny study, just be cautious of whether or not you actually buy into that. That's what I'm saying.
So be aware of the marketing. The marketing is wild out there, just wild as far as supplements, as far as whatever have you. Um, okay, let's talk about. So we did the the boost, we did the Bondia, we did the dentist. That the takeaway from the dentist. I mean, I think the takeaway is just as I was talking with my endocrinologist today. She's like, get the teeth taken care of before we get you started on some bone meds.
Yes, that's a great idea.
That's what we all should be doing. And however we do it, whatever is going on, take care of what needs to be taken care of. And whether or not you're gargling with a baking or swishing with baking soda, right? You said?
Mhm.
Yeah. Um, and what is your view on osteoben and what about
Oh, osteobin, that's the one.
osteoben? Osteoben is designed for health. And what do
So
you
what they do is they get these, they nitpick and get a couple little studies, and then they study like 10 rats. You're lucky if in uh, a supplement study, it's 10 rats. I have to go back to physiology. How do nutrients work? But these studies are designed to sell a supplement a lot of times. So I'm just saying, be cautious, be careful who you listen to. If they're selling stuff and they're talking, it doesn't mean that they're not good people, but a lot of times they're biased.
the osteoben has genistein in it. What's your opinion on that?
Well, genistein is how much is that all that it is?
No, this part of it is in osteoben.
Oh, osteobin.
Mhm.
I'd have to see how much. So that is one thing that has been helpful for people. It's a phytoestrogen from soy, but it is clinic. If it has good amount of genistein, again, I write about this in my book. It might be helpful.
Mhm.
I don't use those things as a way. Now, if somebody had like say a negative 2.5, maybe I'd play around with that, and their CTX was 400. They couldn't take estrogen, and maybe they wanted to play around with these things and see if they could bring that 400 down.
Mhm.
Sure, maybe I'll play with that. That's not but a -4, -4.5, you're going to play with those things? I don't think so. So you have to know how significant your case is. You can have normal bone density and still have advanced osteoporosis if you've sustained fractures that you should not have gotten. Like walking across the lawn and you fell and you broke your femur, or your humerus, standing height kind of falls. You break your wrist, you fell, but it's shattered. It shouldn't have shattered, perhaps. I always want to look at fractures and how extensive they are and what the actual injury may have been.
What labs are doing CTX and P1NP without MD orders? So if it depends on where you live, you can get it with Avexia, who uses LabCorp, or Ultra, I think it is, that uses Quest. That's third-party testing, but there are certain states that you cannot get them in, like New Jersey, California. Can you get California?
Yeah, yeah, yeah.
California.
I belong to a professional co-op and I get really, really steep discounts. And some doctors have that.
Hmm.
And they can order, but it's always going to be LabCorp, not Quest. And that's fine. Let me say one more thing about the bone turnover markers, because some of you now are going to go look at the range. And you always want to look at premenopause. They should take off the postmenopause. Postmenopausal women always are losing. So none of us who are in this specialty are looking at postmenopausal ranges. And when you look at premenopause, it may be, I don't know, I can't remember what LabCorp is. It's like, I don't know, for CTX, it's like 100 or something, or 50 to 600. 600 is not good. Right around in the middle, 275 or so is good. So you don't want to be on the high end of that either. This is complicated. Bone is complex.
Well,
And
and this is the point, because it's complex and we think, oh, here's the DEXA, here's your script. No, no, there's so much more to it than this. And if there's one takeaway, that's the one thing that you'll understand, that it's very complicated. As far as when you get your CTX and P1NP, it's best first thing in the morning. So before 8 o'clock, 8:30.
yeah, and Deb is, by the way, yes, no biotin when you're taking when you're doing these testing, no collagen for 3 days. Actually, it depends on how much biotin you're taking, might be 5 days. You don't want to be taking those things. You have to be well hydrated. Um, and no heavy exercise.
So you're talking about in excess of 300 milligrams of biotin for 5 days. Is that what
Micrograms, maybe.
micrograms? Excuse me.
Yeah, I don't know. I mean, if it's in a multiple, it's probably okay, but I'd still maybe stop for a couple days. Why not?
It makes
Because
sense to stop, right?
the reason is that the biotin is in the test kits. And so it impacts so many tests. And so you really don't want to,
Oh,
you don't want to be having biotin at the same time you're getting a lab test.
how do we swish with baking soda? Dissolve in water?
Yeah, just dissolve it in water, shake it up, and swish it around.
Have you noticed that Forteo or Tymlos is better for migraine sufferers?
No, but well, I do know that Tymlos, one of the side effects can be headaches. Um,
Migraines or headaches?
headaches. And so therefore migraines too, I would imagine, if you're prone to migraines. But again, you got to be well hydrated and all this stuff. Just in general, so many people are not well hydrated.
I think we have a
So
question. What do you want to
I
say?
just want to ask people who are here still. I know this has been a lot, and I'm just wondering, and you can pop it over in the chat. Are you overwhelmed? Are you feeling like you're learning stuff? Um, I'm just kind of wondering how you're taking this, because I know it's a lot. It's been a lot for me, over the years, and that's why I ended up writing a book to sort it out for myself. So I'm just wondering how you're all doing.
Yeah, that's a really good question, because we're going through a lot of things and want to know if this is helpful. As people are writing that in, what is your opinion about um, vegans as far as a
Well, what I can say, I live in Berkeley, and there's a lot of vegans. Vegans can do it, but they have to be so on top of it. And I see tremendous loss. And even people who have been vegans for 10 years seemingly have a very good diet. I'm just saying that's my experience. I get being a vegan. I get I'm a Buddhist practitioner. I have been for 50 years for Vipassana meditation, which is mindfulness practice. But I'm just saying that uh, I was pretty much a vegan for a long time, but I do yogurt now, but I also make sure I do get enough calcium for sure. It's B12, it's vitamin D, it's so many things that can go wrong with being a vegan. So I'm just saying you have to be way on top of it. Look at your bone turnover markers, see how you're doing. Oh, by the way, I do have an osteoporosis myths and facts group. If you want to learn in more detail,
Mhm.
I'll do a whole thing on dental. I do this week, I don't remember what I'm doing it on, but I just did one on bone turnover markers. So when you join, you get a number of very in-depth, uh, you know, videos.
So
But
you're saying two things. You have a Facebook page called
facts, that's free.
Myths and Facts. This is an incredible Facebook page, because you've run it pretty tight as far as not allowing certain things to be up on there. No
I
ads,
don't allow anybody selling anything,
nothing.
period.
Right. Right. And then the comments are they're educational. You'll do educational corners. You'll do a learning question within your group.
But if you want to learn in depth, it's reading the book, it's getting down the language, and considering a master class if you really want to learn in depth over time, because there's a lot, as you can see here, talk about fractures. There's so much more to say about fractures, so, or whatever it is. And that's what I talk about, all this stuff.
So, Leslie, yeah, you're at the start of the journey, and most of this is overwhelming. Yeah, the language, the words, the terminology, it's like Shakespeare. It becomes part of you after a while. It gets into the marrow of your bones, and all of a sudden you're talking about C-telepeptide. And
Well, and like Barbara said it all, I think she said, I like it all, but confused.
mhm,
I get it.
yeah.
It is a lot. And and Connie, but I know you're a chiropractor yourself, so I know that you have kind of a way to view this, so I get that. Bella, you're at the start of your journey. Good for you to show up here, I guess I would say too. And most people are saying they're learning a lot, and good.
And what about vegetarians?
Well, vegetarians, that's a little different because they usually include dairy, and I'm not a big fan of, well, I'm a bigger fan of, say, yogurt, and that type of dairy, rather than slugging. Let me give you one more thing and then I got to go. Can't be late to the movie, Irma. Um, you don't have to get all your calcium from food. It is a ridiculous, harmful myth. I've got people slugging down milk, a gallon of milk a day or whatever. No, you don't. And then they're saying, oh, but I'm getting fortified orange juice. That's a supplement. It's actually calcium carbonate. Why not do calcium citrate, which is better? So if you need extra calcium, do not be afraid to do it, but do low doses, like 200 or 300 a time. That would be natural, like say a yogurt would be. I cannot do a lot of dairy. It's inflammatory for me. So I can do one yogurt a day and that's it. But I can't do Gouda cheese, which I wish I could because it's really, really good. Has some vitamin K in it and all that. But if you have a histamine issue, you can't do the hard cheeses.
Vitamin K2, MK4, high dose. Just before you go.
Vitamin K,
K,
100
MK4.
micrograms is
Mhm,
fine. MK4 is where the studies were.
mhm.
So the studies were 15 grams, three
Milligrams.
milligrams, excuse me, 3 times a day.
Right,
The MK7 is micrograms.
right.
MK7 is simply not the same as MK4. MK4, in my view, would be if you did it at the 45 milligrams, somewhat of a treatment, but we don't have time to really talk about that. I think the MK7 is somewhat helpful, but some people get heart palpitations from it and some other things. So I just don't see the benefit of going over, say, 100 or 150 in the MK2, MK7, K2.
MK7. So, okay. So that was a quick thing. I know you have to go to see Prada. But you didn't really answer the question about the high dose MK4. MK, the MK4 high dose,
The
45 minutes.
vitamin K,
Yes.
MK4, is
Yeah.
what our body produces naturally.
Mhm.
It's what we get in meat products like our ancestors got. I don't eat like beef and things like that. I eat some fish. I eat some turkey. I eat some chicken, not a lot. I eat eggs. I eat dairy. That's where I'm at. So I do lean on getting some of that, but I eat a lot of beans. I load up a salad with beans and tofu and all that kind of stuff. So I get my protein in a variety of ways, and that's what I recommend to people. But vegetarians, at least often they're going to be getting some from dairy, and I think that's a good idea.
Are you seeing clients these days?
I am doing primarily bone density second opinions, so you can go to my website and get that. I consider it sometimes if they've read my book, they're in my master class, but I don't take people who don't have kind of a base of knowledge because I can't teach them everything. That's kind of where I'm at. That's maybe something you do when you work with people, but I don't do that anymore.
Thank you, everybody. Thank you, Dr. Lani. This has been fast. It was very fast.
It's a lot.
It's a
It's a
lot.
lot. I get it. So thank you all for attending and
Interesting.
may your bones stay strong.
Thank you.
Okay.
Bye for now.